Greetings, everyone. It's a pleasure to welcome you all to the next session of GynoScope. Before we get started, I'd like to let everyone know that this session would be recorded, and I hope I have everyone's consent going ahead with the same. Perfect. GynoScope is a unique series envisioned with a singular goal to create a space where young medical minds can come together to learn and question in the field of obstetrics and gynecology. Through GynoScope, we aim to bring to you a range of clinically relevant case presentations, real-time discussions, quiz-based learning, and unique formats like Dr. Nimbkar's Brain Benders. Today we have with us Dharunvishal and Ranjith from Arunai Medical College, Thiruvannamalai, to discuss anemia and pregnancy. We're so grateful for the enthusiastic participation from colleges across the country and for the opportunity to help build a stronger, more connected academic community. Thank you for joining us today, and we look forward to an engaging session ahead.
Good evening, ma'am.
Good evening.
Hi Ranjith. Hi Dharunvishal.
Hi, sir.
Yeah. So let us begin. We'll follow our regular format. Good evening, everyone else. A format of the students presenting the case first, and then it will be followed by the question answer session. So quickly, within 5 minutes, start presenting the case. All the best, and I hope this is a good discussion. Okay.
Sir, only one thing, sir. Before starting the presentation, myself and my co-presenter are not in the same place, sir. So we will be presenting like from different IDs. Is it okay?
Yeah,
Fine with you, sir?
absolutely fine. Yeah,
Okay.
absolutely. And if you want, one person can present the entire case and both can do the answering part. Even that works.
Okay. Okay, sir. Then I'll present complete case. Then we will be discussing. Okay, sir.
Okay, just make sure that the internet pack and all have been or Wi-Fi has been connected to and your mic is close to your speaking wheel. Okay.
Yes, sir.
Okay. Start.
Can I start, sir?
Yeah, absolutely. All the best.
Good evening, everyone. Today, myself, Dharunvishal and Ranjith MS are here to present an anemia complicating case in pregnancy. Our patient, Mrs. V, 25-year-old, educated up to 10th standard, wife of Mr. G, a 30-year-old, working as farmer residing at Chingam. She belongs to lower middle class according to modified BG Prasad scale with obstetric score of Gravida 2, Para 1, Live 1. Her last menstrual period is 29 October 24, gestational age of 36 weeks 3 days, an expected delivery date of 5th August 25. She is booked and immunized at Chengam PHC. Her blood group is O positive. She came to the OPD with a chief complaint of EC fatigability for past 1 week. History of presenting illness. Patient was apparently normal before 1 week and developed lethargy and EC fatigability. There were no history of swelling of leg, abdomen, face, arm, no history of headache, blurring of vision, epigastric pain, and decreased urine output. No history of breathlessness, palpitation, chest pain. No history of burning micturition. No history of bleeding per rectum, melena, hematuria, hematemesis, and hemoptysis. No history of chronic diarrhea. No history of worms and stools. No history of bleeding PV or leaking PV. No history of fever with chills and rigor. History of present pregnancy. She was conceived spontaneously 2 years after last childbirth, booked and immunized at Chengam PHC. She completed 9 antenatal visits. First trimester. Number of visits, 2 visits. It was a spontaneous conception. Pregnancy was confirmed by urine pregnancy test kit at 40 days of amenorrhea at home. No history of nausea, vomiting, no history of fever with rashes, no history of radiation exposure, no history of drug intake, no history of bleeding PV, no history of pica. Folic acid supplementation was taken. Single dose of TD was given. Weight gain in the first trimester was about 800 grams. Dating and nuchal transfusion scan was done and found to be normal. All routine blood investigations were done and found to be normal. Moving to second trimester, number of visits 3, quickening felt at 5th month. Anomaly scan was done and found to be normal. Weight gain in the second trimester is about 3 kgs. Iron, folic acid, and calcium tablets were given. No history of headache, blurring of vision, pedal edema, normal OGCT test. Blood pressure was also found to be normal. No history of pain in abdomen or bleeding per vagina. Moving to third trimester, number of visits 4. Fetal movements were perceived well. Growth scan was done and found to be normal. Weight gain during third trimester is about 8 kgs. History of fatigability and lethargy was seen. No history of bleeding or draining per vagina. Moving to menstrual history, she attained menarche at 15 years. She had a regular 30-day cycle with normal flow of 4 to 5 days. Changes 3 pads per day, not associated with pain or clots. Her last menstrual period was 29 October 24. Past obstetric history. Conceived spontaneously at age of 22. First, second, and third trimester were uneven full. Gave birth to a male baby weighing 2.8 kgs via normal vaginal delivery at Government Hospital, Thiruvannamalai. Baby cried immediately after birth and there were no postpartum complication, no NICU admission. Baby exclusively breastfed for 6 months and no history of any blood transfusion. She continued to take postpartum iron and folic acid supplements. Marital history. Married at age of 20 years. It was a non-consanguineous marriage and no history of contraception usage. Past history. Not a known case of diabetes, hypertension, epilepsy, asthma, tuberculosis, and thyroid disease. No history of previous surgeries, no history of blood transfusions. Family history. No history of thalassemia, sickle cell anemia, history of any blood transfusion or blood dyskaryosis. Personal history. She consumes mixed diet, normal bowel and bladder habits, normal sleep-wake cycle, no history of any alcohol or substance abuse, no history of drug allergy. Diet history. It was calculated by the 24-hour recall method. Total calorie intake was about 1900 kilocalories. Recommended calorie 2525 kilocalories. It was deficit of about 625 kilocalories. Total protein intake of about 25 grams. Recommended protein 65 grams. From diet history, the patient did not have any iron-rich food in her diet. Frequency of non-vegetarian diet is also restricted to weekends. Treatment history. She was treated for anemia with injection iron sucrose 4 dose, which was diagnosed at 28 weeks with hemoglobin of 7.3 gram per deciliter. Moving to general examination, the procedure was explained to the patient, consent was obtained and examined in the presence of a female attender. Patient is conscious, cooperative, well-oriented to time, place, and person. Patient is comfortable at rest and non-dyspneic, moderately built and nourished. Pale are present, no icterus, no cyanosis, no pedal edema, no lymphadenopathy. Head-to-toe examination. No dry lusterless hair, no glossitis, no angular stomatitis, no platanoichia, no koilonychia. Spine appears to be normal and thyroid appears to be normal and breast appears to be normal. Vitals. Pulse 86 beats per minute, regular in rhythm, adequate volume, no radio-radial delay, no radio-femoral delay. Temperature 98 degree 4 Fahrenheit. Respiratory rate 14 breaths per minute, thoraco-abdominal type. Blood pressure 120/80 mmHg, measured on right arm in sitting position. Height 156 centimeter, SpO2 99%, and pre-pregnancy weight 51 kgs, current weight 62 kgs, BMI 25.9 kg per meter square. Obstetric examination. Inspection. Abdomen longitudinally distended, flanks full, umbilicus is central and everted, linea nigra, stria gravidum seen. All quadrants move equally with respiration, no scars and sinuses, hernial orifices were intact. Palpation. Fundal height corresponds to 36 weeks of gestation. Symphysis fundal height 34 centimeter. Abdominal width 103 centimeter. Fundal grip soft, broad, non-independently palatable of the body, suggestive of breech. Umbilical grip, right side, multiple small nodules, probably limb buds. Left side, smooth, curved, uniform resistance, probably spine. First pelvic grip, small, hard, round mass independently ballotable of body, suggestive of head. Second pelvic grip, findings of first pelvic grip were confirmed in second pelvic grip. Auscultation, fetal heart sound 140 per minute, heard on left spino-umbilical line. Other system examination, CVS examination, S1, S2 heard, no murmurs. RS examination, normal vesicular bed sounds heard, no basal crepitus. CNS, no focal neurological deficit. Summary. A 25-year-old Mrs. B, G2, Gravida 2, Para 1, Live 1, gestational age of 36 weeks, 3 days, with last menstrual period 29 October 24 and expected delivery date 5th August 25, came with complaints of EC fatigability for 1 week, who on examination presents with single live fetus in cephalic presentation with good fetal heart sound. She is moderately anemic, well compensated, not in failure, who has been admitted for evaluation and management of anemia. Diagnosis. A 33-year-old Gravida 2 Para 1 Live 1 at 36 weeks, 3 days of gestation with anemia complicating pregnancy with a single live fetus in cephalic presentation, not in failure, not in labor. Thank you, sir.
Great presentation. Pretty well done. And also like the format of your PowerPoint. Very nice. So could you just go back to your first slide?
Thank you, sir.
By the way, someone had just Uzma had commented that we are not audible. Is the presenter and am I audible? Everyone in the audience, please let us know.
Yes, sir.
Okay. Okay. Yeah. So could you just go on to the first slide?
Okay, sir.
Okay. So now in your demographics, could you tell me what are those important points pertaining to your history of an anemic that are significant? They may or may not be abnormal in your case, but what are those important points in demographics of any history in relation with anemia?
Sir, first of all, we can go with age, sir.
Hmm.
Most commonly, teenage pregnancies are uh, more risk for anemic pregnancy, sir.
Why?
So one minute. Sir.
The other one can answer
Yes, sir.
if there is any issue with this. Yeah. So could you tell me why is age and teenage pregnancy a significant factor for anemia in pregnancy?
Sir, the reason might be like since they have like uh, menstruation, so that they would have anemia, sir. Like there will be increased amount of blood loss during that period, sir, for
But
teenage.
even the adults menstruate, so that actually cannot be the cause
But the
of anemia.
compensation occurs with the age, sir, for the women.
Compensation, okay. But what if it's a teenage age group consists of 13 to 19 years of age?
Yes, sir.
Is there any issue with your presentation? You have been consistently changing something.
So, no, sir,
So,
I just wanted to unmute, so just I went out.
okay. So the point here is that it can even be a 19-year-old female who is menstruating since 7, 8 years now. Why should she be at a higher risk for anemia? So definitely it is not the compensation factor.
Mostly adolescent growth, they require more amount of energy during adolescent, and it is a growing phase, sir.
Yeah,
So,
very good.
so
So the
in growing
micronutrients
phase,
are required for growth. Yeah.
yes, sir. So in a growing phase, if they are going to become pregnant, then there will be more increase in demand for both maintaining their growth as well as the fetus, sir.
Yeah, very good. So basically, the adolescent age group or the teenage age group is also about the physical growth of that female. And it is if it is going to be concomitant with a pregnancy that superimposes on that growing phase, then you are going to have a lack of nutrition and a lack of iron that is going to be available for erythropoiesis. Fine. The second part that you have mentioned is about 10th standard education. So basically, what is your education status and your occupational history? How is it significant?
Sir,
Sir,
education trans I'll answer. Like if she is educated up to higher school, she would be knowing about her reproductive health, sir. So since she is only educated up to 10th standard, she might not know about the do like she might not have been educated for reproduction and childbearing, sir. And occupation wise, her husband is farmer, so there is an increased risk of hookworm infestation, and hookworm infestation also plays an important role in anemia, sir. Chronic blood loss due to hookworm infestation.
Very good. So your socioeconomic history, basically your educational status and your occupation history is significant because it not only educates you about what is healthy, but it also gives you the financial access to a better diet and also gives you the knowledge about early registration, starting those iron pills, the significance of having them because you cannot any longer say that the patient cannot afford iron. Affordability is not an issue. It is more about the accessibility and the awareness because now under Anemia Mukta Bharat, every pregnant female is going to get those capsules for free. But to know that they do get this and there are these provisions and the importance of taking it lies in their educational status and also the occupational part of it. Because if you have a female who is also a farmer, the wife who is working in the farms as well, she's probably not going to get as much time to visit the OPD. She's going to be a poorly followed up patient who eats less. Often these laborers, these farmers and all, they don't even have proper diet. They have they have a diet which might just be, they can just spend the entire afternoon having a cup of tea or something, basically things that contain tannins and all. So because it is cheaper, and that is going to also impede your iron absorption. So all these factors do play a part. So that also explains your lower middle class status, which I would say is the. Uh, but then, by the way, you have used about prasad. Is prasad used for farmers who live in rural areas, or is it for urban areas?
Sir, actually, Prasad can be used for both urban and rural areas, sir. If we want just a rural area, we can use either Uday Parik, and if want just urban area, we can use modified Kupusami scale, sir.
Okay, very good.
Because most of us are prevalent with BG Prasad, we use BG Prasad, sir.
Okay, that's fine. Good enough. So you have mentioned that her obstetric score is gravida to para 1 living one. How is your parity responsible for anemia?
Sir,
Multi
multiparity is a risk factor, sir. Uh, Due to if the interpregnancy intervals are less, then the rate at which the iron stores are replenished are also lesser. So it
Why?
will increase the chances of anemia.
So for
Why though?
replenishing of iron stores, it takes about 6 months, like for proper replenishment. So if there is interpregnancy interval lesser than that, she is prone for anemia, sir.
Very good. Also, during lactation, you are going to have iron that is also being given through lactation to the fetus in some amounts, not much. So because of that factor as well, and her own body's replenishment, the iron stores do not get enough time to build up. So your interpregnancy interval plays a role in that. And of course, multiparity as the parity increases, obviously the interconception period is also going to reduce with that. So the body just never gets enough time for it to replenish its own store. Okay. So she is 36 weeks and 3 days. Okay. Could you tell me um, what is the concept of physiological anemia and how is it correlated with your gestation age?
So
Sir,
physiological anemia is common in the second trimester, sir. And the concept
Okay,
of
why?
physiological anemia, the dilution increases after first trimester, sir. Like it peaks around hemodilution will peaks around second trimester, sir. Like 24 to
Why?
32 weeks. So there is like as the fetus grows, there is increased amount of demand for the increased amount of demand for the nutrients, sir, for fetus.
Okay.
So the
Um,
viscosity should decrease, sir. So in order to decrease the viscosity and increase the blood supply, like there would be the plasma volume increases by 40 to 50 percentage, whereas the RBC volume increases by 20 to 30%. So there is a relative disproportionate relative hemodilution occurring, sir. So this is physiological anemia, sir.
Correct. So the point is, as you mentioned, to put it clearly, in the second trimester, as is also reflected by the grading of severity by WHO and ICMR, I'll come to that later. In the second trimester, the retention of water or the increase in the plasma volume is much more than the increase in the number of RBCs. So basically, the hemodilution peaks in the second trimester, or to be more precise, at the exact midpoint of pregnancy, which is between 20 to 28 weeks of gestation, which is why your HB drops, even your hematocrit drops significantly and maximally in this middle part of your pregnancy. Whereas before and after that, it is still low, but still it is higher than your middle second trimester, and hence your physiological anemia is going to develop. And obviously, as you mentioned, the plasma volume increases by 40 to 50%. That is, your water in the body increases by 40 to 50%. But your RBCs only increase by 20 to 25%. I mean, obviously, retaining water is much easier than producing a new RBC, which is why the rate of production of RBCs is always going to lack the amount of water that is retained. And this leads to a state of hemodilution. Correct. So this is physiological anemia. Could you tell me why is this required and why should this plasma retention happen?
Sir, it increases the it decreases the viscosity of the blood, sir. So with decrease in the viscosity, there will be good flow across the placenta, sir.
Yes, correct. Very good. So your physiological anemia is essential because it improves your fetal perfusion through the placenta. And also because you have a new fetus, a new individual in the body of the mother. So as to supply that, there is a need to retain water, which is reflected by your increasing renin and ADH levels during pregnancy. So could you tell me what is the grading of anemia in pregnancy or severity of anemia?
Sir, there is two gradings, sir. WHO grading and ICMR grading and CDC grading,
You
sir.
can just call it WHO. Who is,
WHO grading, sir.
yeah, tell me.
So it can be classified into mild, moderate, and severe, sir. And like
Okay.
in mild anemia, like there would be 10 to 10.9 gram per deciliter hemoglobin, sir. And in case of moderate anemia, there would be 7 to 9.9 gram per deciliter. And in case of severe anemia, it will be less than 7, sir.
Okay. What is the difference between ICMR and WHO?
So there will be a very severe anemia which is less than 4 gram per deciliter. So
No, I'm asking what is the difference between the definition of anemia in the ICMR and WHO classification?
Sir, for anemia, so diagnosing anemia, there is for different trimesters, there is different levels of hemoglobin used in case of WHO, sir. In case of WHO, it is less than 10, it is categorized as
Don't
anemia.
call it WHO. It is very wrong. It is
Sub-
not WHO. It is WHO.
sir, can I complete it, sir?
Yeah, sure. Please do it.
According to WHO, in order to classify as anemic pregnancy, the hemoglobin concentration should be less than 11 gram per deciliter and hematocrit should be less than 33%.
Okay, so the difference is basically in your very severe, which is not defined by WHO, but ICMR defines it as less than 4. And also in mild anemia, ICMR says that mild anemia is between 10 to 11, whereas WHO says it is between 9 to 11. So very basic difference, but yeah, you should know about it. And that is the only difference. ठीक है. You have mentioned about the blood group. How is blood group significant in this case of anemia?
So for transfusion purposes and to rule out RH negative pregnancy, sir.
Okay, RH negative pregnancy, yes. And anything else with regards to purely anemia?
We don't know, sir.
Very simple. Remember that when you're managing a patient, you have to take into consideration that at the end of your pregnancy, you're going to have the process of delivery. Whenever you're delivering, you are going to require blood bags. So if a female is, let's say, something like AB negative, which is a blood group that is very difficult to find, especially because your patient has been booked at a PHC. So if she has a rare blood group, the blood is not going to be available, and you would rather want to refer her to a tertiary care at that point. where the availability of blood is going to be much more and much better than that. And if not, she can also gather a few people, family members or people from her neighborhood who are going to be able to donate the same rare blood group. So this planning process cannot just be done overnight when she comes in labor. It has to be done beforehand, and hence the referral to a tertiary care center is going to be essential in cases of these rare blood groups. Of course, you mentioned about Rh negative pregnancy, definitely, but in terms of anemia, you have to think about the time when the delivery is going to be required, where she will require a couple of blood bags to be reserved for her delivery, especially if it's a cesarean section. Okay,
Okay,
so
sir.
next slide. Okay, so I mentioned the history of easy fatigability. Now, fatigability in pregnancy, why? Because of anemia. And what are the other differences?
So other differentials can be due to cardiac causes, sir, or renal causes.
Cardiac causes like,
CCF, sir, congestive cardiac failure.
okay, what else?
And any valvular heart diseases, sir.
Yeah, very good. Any valvular
R-
heart
r-
disease, definitely.
Rheumatic heart
Anything
disease,
that is going to lead to your pulmonary effusion, like mitral stenosis,
aortic stenosis, and all.
aortic stenosis, mitral regurgitation, or Eisenmenger, any of these that leads to an increased pulmonary pressure. So backward flow is going to be increased. Okay. What else? First is your cardiac disease. Second,
Anemia and
Uh,
respiratory diseases,
okay, anemia.
which
Why
generally
should anemia lead to fatigability?
like decrease oxygen carrying capacity, sir.
Very good. So decreased oxygen carrying capacity to your muscles, and hence your
Muscles and
muscles might just get fatigued.
causes hypoxia and
Yeah, very good. What else? Easy fatigability and anything else? Fatigability, a person is walking quickly and that person is feeling much more fatigable during pregnancy now. Why? The same thing that you mentioned for cardiac disease.
sir, can you repeat the question, sir?
What are the other reasons that anemia is going to lead to fatigability apart from the reduced muscle oxygen carrying capacity to muscles?
Any other chronic renal diseases, sir?
No, why anemia? I'm asking about very specifically anemia.
Just
The same thing
due to
as
the
you mentioned for heart. For heart, congestive anemic cardiac failure. Anemic cardiac failure is going to lead to accumulation of fluid in your lungs, and that is going to make
pulmonary
the
edema
person a
due
lot.
to
Yeah,
acute
exactly,
pulmonary
because
edema
of
due to
heart
CCF,
failure.
sir. Complicated due to
Exactly. So anemia leading to heart failure. Why?
yes, sir.
Because in anemia there's going to be hyperdynamic
Increase in
circulation,
circulation.
and that
Yes, sir.
yeah, and that can lead to cardiac overload and cardiac failure, which is going to lead to pulmonary effusion and eventually increased fatigability and reduced stress tolerance. Okay, so cardiac disease is done, anemia is done. What are the other causes of fatigability in pregnancy?
Respiratory diseases, sir, like
Yes,
pulmonary
like
hypertension also can cause, sir, but it will be severe than the in case of anemia and cardiac diseases, sir.
okay, any pulmonary disease, it can be restrictive or obstructive, uh, wherein you can have basically reduced pulmonary capacity leading to breathlessness that leads to fatigability. So yeah, respiratory causes as well. And other orthopedic or rather musculoskeletal causes, if the patient has any myositis or any autoimmune muscle
If there
disorders,
is
then in that case.
if there is any electrolyte imbalance due to
Yes, electrolyte
excessive
imbalance,
vomit,
very common, very
sir,
correct.
hyperemesis,
So hyperemesis, very good, good answer. So because of hyperemesis and which exact electrolyte imbalance, if you have to point out to
sodium, sir,
one,
sodium,
more than sodium, something else.
potassium, sir.
Yes, potassium. Hypokalemia. Hypokalemia is going to lead to um, problems in your in your neuromuscular conduction, and that is going to eventually lead to muscle fatigue. Okay, next slide. So there is no history of swelling of legs, abdomen, face, and arms. What are the differentials of swelling of legs, abdomen, face, arms in pregnancy?
Sir,
sir.
it could be due.
Swelling of face could rule out any renal abnormalities, sir. And Normally, if swelling of abdomen can be due to any ascites or any chronic liver pathologies. Generalized edema, we have asked for swelling of legs.
Okay, swelling of legs, abdomen. Okay. So what are the other differentials? Hepatic disorders has been mentioned. You have mentioned already about anemia. What else?
So to rule out congestive heart failure in this case also, so since the patient has
Okay, so congestive heart failure, one of them. Yes. What else?
and diseases complicating pregnancy such as preeclampsia and eclampsia,
Very
sir.
good. Preeclampsia. Very good. What else?
And any renal
Chronic renal
pathologies,
diseases, sir.
Very good. Chronic renal disease leading to proteinuria. Correct. What else?
any any protein losing enteropathy, sir, or
Very good.
malabsorption
Protein
syndromes.
losing enteropathy. Like any one example?
Uh, I don't know.
Malabsorption syndrome. Very easy.
Malabsorption
Or
or like
GRDS.
Crohn's disease and
Inflammatory
also
bowel
Ah,
disease.
disease,
IBDs. All the
celiac disease.
IBDs. Celiac disease. Correct. Apart from that, any endocrinological disorder that can lead to swelling of legs,
Hypothyroidism, sir.
hypothyroidism. Okay, are you hypo or hyper?
Hypo, sir. Hypothyroid.
In which cases do you find myxedema? Stick with your answer. You are correct. It is hypothyroidism. That is not.
Hypothyroidism.
Yeah, correct. So hypothyroidism. What is the difference between myxedema and your pedal edema of other causes?
So mixed edema like starts to develop around the eyes, sir. First of at initially, sir.
Oh,
But
very
in case
simple.
of
There is
other
just one simple word that I need to hear from you. People have
thyroid
been answering it.
causes.
People have been answering it correctly. It is of the non-pitting type, whereas your pedal edema of other causes is always going to be of the pitting type. So pitting and non-pitting is the difference between your mixed edema and your other causes. Okay. If you have unilateral swelling of your leg in pregnancy, what is going to be your differential?
Sir, it could be
Filariasis.
due to cellulitis filariasis. Deep vein
Okay,
thrombosis.
filariasis, very good.
Deep vein
Deep vein
thrombosis,
thrombosis,
sir.
cellulitis, correct, very correct. So that any lymphatic disorder like lymphangiectasis or lymphangiectasis or your filariasis, or as you mentioned, DVT or cellulitis, correct. You have mentioned about no history of headache, blurring of vision, epigastric pain, which is going to rule out your preeclampsia. Okay. No history of breathlessness, palpitation, or chest pain. Any differentials for your breathlessness in pregnancy?
Like if there is
Congestive
presence of
cardiac.
What is the commonest? Tell me the commonest first.
any heart disease complicating pregnancy, sir.
Is that the commonest?
Obesity, sir.
So it's a physiological compensation occurring at the
Correct.
pregnancy, sir.
So as
Due to
Shivani
pregnancy.
also mentioned, correct. Physiological, basically as your trimesters increase, as you are in the later part of your third trimester, just because of the gravid uterus, whenever you lie down, it compresses upon your lung fields, it presses your diaphragm upwards, and that leads to breathlessness. So, physiological dyspnea in pregnancy is the commonest cause of breathlessness. So, remember, before you go ahead with, how often do you even see cardiac disorders in pregnancy? You do not see them much. Just because they're admitted, it doesn't make them common. The commonest is always going to be physiological thing first, then followed by all other causes. Okay. So what are the other causes? You mentioned about cardiac. What else? Am I audible?
Yes, sir.
Okay. So
Preeclampsia,
what are
sir.
the other causes? Okay, preeclampsia, breathlessness. Okay, I would not rather call it preeclampsia. I would rather say severe preeclampsia, pulmonary edema. Okay, fine. What else?
Thyrotoxicosis.
Thyrotoxicosis. Okay, quite rare. Okay, but what else? A few commoner causes.
Obesity, sir.
Obesity, not much. What else apart from that?
Valvular heart diseases, sir.
Heart disease already done. It's a medicine question. I mean, one of the commonest questions in symptomatology in medicine about what are the causes of breathlessness.
Sir, respiratory causes like pleural effusion, pneumothorax.
Okay, something common in patients with pregnancy and respiratory system, asthma,
Yes, sir.
exacerbation of asthma because of your
Yes, sir.
altered immune system. So yes, definitely. Apart from that, if you're going to be talking about breathlessness, then also polyhydramnios or multifetal gestation that can lead to your excessive compression. That is pathological. That is not going to be physiological. Cardiac, you have already mentioned, and respiratory. So all these are the major causes of breathlessness during pregnancy. Palpitation and chest pain, very classically seen in cardiac disease, but palpitation, do you see it in anything else apart from cardiac
Hyperthyroid.
disease? Yes, hyperthyroidism, a very classical symptom of hyperthyroidism or thyrotoxicosis. Okay. Chest pain, commonest cause in pregnancy.
Exaggeration of anemia, sir. Or a GERD, sir. Gastric
GERD, yes, very good. GERD. Could
reflex
you tell me
disease.
what is the cause of GERD in pregnancy?
Due to increased vomiting sensation. So,
Yes, but why?
HCG,
Why? That is
HCG,
exactly what.
beta HCG levels will be increased, sir.
Oh, but yeah, that is what explains hyperemesis. Why should it lead to GERD? GERD is very common in pregnancy. What is the reason?
Sir, progesterone is the key pregnancy hormone and relaxes the lower esophageal sphincter, so there is an increased
Correct.
acid
No
Excellent
reflux.
proper
answer.
closure of lower esophagus.
Yes, correct answer. So basically, progesterone is a relaxing hormone that relaxes everything in your body. It includes your lower esophageal sphincter. That is one of the reasons. Any other reason? GERD in pregnancy?
Sir, the baby is growing and it puts additional pressure on the mother's abdomen.
Correct. Yes. Yes. So
So
basically, increased gastric pressure leading to reverse peristalsis and delayed gastric emptying that leads to GERD. Correct. Apart from that, one
yes,
more thing, very common, very commonly neglected. आंखों के सामने है लेकिन it is like before my eyes, but I just tend to miss it out. What is it? Very common. Your iron supplements or calcium
yes, sir.
supplement, both of them are going to cause gastritis. We give it to every patient and then we treat them with pan 40, that is pantoprazole, or we give them Ondem. Now remember that every time you're giving Ondem or even worse, pan 40, you're suppressing your gastric acids. And suppression of gastric acids impairs your iron absorption. And once your iron absorption is impaired, you are leading to anemia. So giving PAN 40 as a treatment of GID in pregnancy is purely idiotic. It is what poor clinicians are going to do. Never do that. Find the cause of that GID, correct it, give head elevation, probably change the salt of iron, or just give it parenterally if the patient is anemic. But do not give pantoprazole or ondansetron for treating GID immediately unless you do know that there is something like a gastric ulcer that the female has. So remember that the commonest cause of GID in pregnancy is exactly what you have been giving her, calcium and iron. And I definitely can afford to stop both these drugs because these two are important drugs, but they are not important enough for me to warrant her living a life full of GID. It's okay if she doesn't get calcium for a few weeks. It's okay if I'm not able to give her oral iron for a few weeks. I can give it intravenously. I can even give blood later on. But her GID is causing distress. And so, can tablet doxinate be given? Doxinate contains doxylamine and pyridoxine. Yes, you can give it because doxylamine is only a muscle relaxant, and your pyridoxine is a good drug that is going to increase your dopamine levels, and hence, yes, you can give it. It's a good drug to give. It won't cause your suppression of acids. Fine. So you have mentioned no history of burning micturition. Why have you mentioned it in this case?
Sir, to rule out any urinary tract infections, sir.
Okay, of course, but then why in a case of anemia?
So infections
Generally
are
in
common in case of anemia, so due to decreased immune response, sir.
Okay, not really. Your immune
sir,
response is altered. I wouldn't say reduced. Always use the word altered. And that doesn't lead to UTIs. No. There is some other cause of UTIs in
sir,
pregnancy. What is that cause?
urinary tract infections may increase the level of hepcidin in the pregnant mother, sir. So which will
Very
lead
good.
to defective iron absorption.
Excellent
She
answer.
can result in iron deficiency anemia, sir. So in pregnancy, we should treat asymptomatic bacteria. Another cause is like chronic pyelonephritis or any urinary tract infection can also decrease the erythropoietin from kidney, sir. So
Amazing
which will
answer.
also,
Beautiful answer. Very good answer. But could you just tell me once, why should the risk of pyelonephritis or the prevalence of pyelonephritis increase in pregnancy?
sir, as a result of pyelonephritis, the erythropoietin secretion from kidney is
No.
affected,
Why
sir.
should the risk or the prevalence of pyelonephritis increase during pregnancy?
Like again, progesterone, sir. Like it is a smooth muscle relaxation, so like
The gravid
the
uterus
bacteria
is
will
going to compress on your ureter. And the moment your ureter is compressed, there is hydronephrosis and hydroureter. And that accumulates the urine in your kidneys. Along with that, you also have insulin resistance in your body because of your normal pregnancy related changes. And that increases your threshold or that increases your chances of getting GDM. So a person who has high amount of sugar that is being secreted and excreted in the urine, and that particular urine is getting accumulated in my kidneys. So sugar, glucose plus urine forms a rich medium, very good medium for microbial growth, and that is why there is an increase in chances of pyelonephritis. Also, since we have spoken about pyelonephritis in any way, pyelonephritis is mostly caused by gram-negative organisms. Gram-negative organisms release endotoxins. Endotoxins are known to also initiate preterm labor,
labor.
which is also why these patients are very much prone to going in preterm labor. But there is a catch here. If there is a risk of preterm labor, you do give these patients steroids. But if you give this patient steroid, a person who has chronic pyelonephritis, you would instead push her into a state of sepsis or even septic shock, which is why you cannot even give these patients steroids because the immune suppression and your bacteremia that can result because of that can be deadly. Hence, you have to just hope that preterm labor या फिर extreme preterm labor में patient ना जाए. Anyway, the point here is pyelonephritis, very common. You mentioned the reason correctly, and that will increase the hepcidin levels. Any chronic inflammatory state is going to increase your hepcidin levels, and that is going to impair your iron absorption. Now that you have mentioned hepcidin, I would want you to tell me how is hepcidin and pregnancy regulated, or basically, how does pregnancy regulate the levels of hepcidin in my body?
Sir, hepcidin is a protein, sir, and it regulates the transferoprotein receptor in the plasma membrane, which regulates the exit port of
Of
the
of it is just
ferrocin,
ferroportin of which cell?
duodenum and jejunum mucosas.
Yes, correct. Continue.
So it regulates the exit port of duodenal and jejunal cells. By the way, it is controlling the regulation of iron, sir.
It is a negative regulator for iron absorption, sir.
Yeah, correct. So basically, ferroportin is a molecule or a transporter that transports iron from the mucosal cells of the duodenum to the transferrin molecule that is waiting for it in the bloodstream. So the transferrin is going to eventually take it to the bone marrow and the liver for storage and erythropoiesis. So between this gut, basically your intestinal cell and your blood, is this ferroportin. Now, hepcidin levels in pregnancy, do they increase or they decrease?
Decrease, sir, to enhance iron
Yes,
absorption.
correct. So basically, because my body recognizes that there is an increased need for iron during pregnancy, the levels of hepcidin reduce. during pregnancy physiologically so that the ferroportin activity increases. And that is going to increase your iron absorption during pregnancy. So it's an evolution wala thing that the body has developed over several levels, several, what do I say, generations, that it is going to increase your iron absorption for the sake of the baby and the mother herself. This same ferroportin molecule is also present at some other location. Which is that?
Bone marrow, sir.
No. I mean, why should bone marrow have it? Bone marrow only has erythroid receptors. It won't have ferroportin. A very important place where these molecules are present.
Brain, sir.
And brain, why does brain require iron? So the answer is
Macrophages,
ferroportin. Yes, you would want to try. What is your answer?
macrophages and liver, sir.
No. So ferroportin is also present in your syncytial trophoblasts of your placenta. So what they do is they transport iron from maternal bloodstream into the placenta and eventually to the fetus. So basically, the work of that ferroportin is to pull whatever iron is present in the mother and send it to the fetus. Which is why even if you are getting a mother who has iron deficiency, very severe iron deficiency anemia like HB of 3, the fetus will still be born with an HB of 16 or 17, which is normal for it. Why? Because the baby, like a parasite, is pulling out all the nutrients, including iron, from the mother. So this ferroportin is also present in the syncytial trophoblasts, which is why iron deficiency anemia in the mother is never going to lead to or is never going to cause iron deficiency anemia in the fetus. Fetal anemia concomitant with maternal anemia. When will this occur though? Is there any instance where maternal and fetal anemia is going to occur together?
In severe anemia, sir.
I literally just explained that severe anemia is not going to lead to fetal anemia. So what is the other possibility in which maternal anemia will lead to fetal anemia? Shweta, you have mentioned Rh negative, but will Rh negative pregnancy lead to maternal anemia? It won't.
Uh,
So there is only one reason in which
Thalassemia.
does either one of you want to attempt any possibility, maternal and fetal anemia together?
Thalassemia, sir.
Thalassemia, I mean, okay, possibly if the mother also has thalassemia and because of autosomal recessive pattern, the fetus also develops it. But okay, I will accept it as an answer. But anything better than that? There are three answers that I'm waiting for.
for any inherited conditions of anemia, like
Like,
enzymopathies, uh,
like,
enzyme defect, membrane defect, and hemoglobinopathies.
not really. So see, so if your fetus has, let's say, G6PD deficiency, it is not going to manifest in utero unless you give some drug that causes new fetal hemolysis. The answer is if you have autoimmune hemolytic anemia, then the IgG is going to cause RBC destruction in the fetus as well as the mother. So the first cause is hemolytic anemia, autoimmune hemolytic anemia. The second cause, wherein there is anemia in both of them, is sickle cell anemia, wherein in the mother there is going to be splenic sequestration of RBCs because of spleen destroying them, splenomegaly, and the same sickling is going to block your spiral vessels in the placenta. That will lead to reduced perfusion of the fetus. So it may lead to IUGR, but the chances of anemia are less, but possible. And the last one, and one of the commoner ones, is going to be parvovirus B19. Parvovirus B19 is going to cause anemia because of aplastic anemia. Aplastic basically marrow suppression in the mother as well as in the fetus. So that's a very important cause wherein if your fetal MCA PSV is increasing and your mother's also anemia is not getting corrected and you're not able to find the cause, in that scenario, you have to do maternal parvovirus B19 PCR so that you know that the mother and the fetus, they both may be affected by parvovirus B19. So these are the causes which will have maternal and fetal anemia concomitantly. All the audience, I hope you all have understood. I would just want to know in the chat if you understood this concept. Anyway, uh, kindly let me know in the chat. Before that, I'll be proceeding. So no history of bleeding per rectum, melena, hematuria, hematemesis, and hemoptysis. Uh, so basically, you have ruled out bleeding from any orifice. Now, could you tell me what are the causes of bleeding per rectum in pregnancy?
For any inflammatory bowel disease or
Yes, correct. Like which is the commonest that leads to hematochezia or melena?
ulcerative colitis.
Okay, fine. What else? Bleeding per rectum, commonest causes in pregnancy. Very
Crohn's
common.
disease, sir.
No, something much more common.
Infestations of
Fistula,
hookworms, sir.
anal
Okay,
fissures.
but that is going to not lead to hematochezia. That is going to lead to occult blood in stools, which is going to be only
Hemorrhoids,
detected
sir.
on, yes, correct, hemorrhoids. External or internal?
Internal
Internal, sir.
hemorrhoid.
Internal hemorrhoids. Internal hemorrhoids are caused by portal hypertension. It is going to be external hemorrhoids along with fissures because of your physiological, not physiological technically, a very common cause in pregnancy, that is constipation. So because of straining and constipation, that is going to lead to continuous blood loss from your anus. You mentioned about infestation. Which are infestations?
Sir,
Ankylostoma
hookworm,
duodenum, Theater
Hookworm,
American.
yes. And what is the other one?
Schistosomiasis.
So something much more common.
sir. Nectar americanus.
Ankylostoma.
Yes, correct. So what is occult blood loss and which is a test used to diagnose or detect it?
So we will check for any hookworm egg in the uh,
Okay, hookworm egg or ova can be seen, but how do you diagnose occult blood loss? What is occult blood loss in stools? What is the meaning?
There will be no visible loss of blood, sir.
Yes, very good. So only microscopic blood. That
Microscopically,
is, yeah. So what is the name of the test?
fecal occult blood test.
No, the name of the test is Guaiac test. So the spelling is GUAIAC. Guaiac test is going to be done to check for occult blood loss in the stool. So you mentioned about hookworm and Necator americanus.
American.
Could you tell me what is the daily blood loss estimated from both of these?
Sir, in case of Ankylostoma duodenum is 0.2 ml per egg, sir, per worm. And in case of Nectator americanus, it is 0.03 ml, sir.
ml per worm per
Worm,
day.
worm per day,
per
sir.
worm per.
Remember that per worm per day. Yeah. So even if like let's say ankylostoma or hey, if you have ankylostoma and it leads to 0.2 ml blood loss per worm, and you have 100 worms. So remember, if you even have 100 worms, which is quite a lot, they are always in thousands. So even 100 worms are going to cause 20 ml blood loss in a single day. Imagine if it is 1000, it is almost 200 ml of blood loss. 200 of ml of blood loss, if you're having it for 5 days, it leads to almost 1 liter of blood loss, which is equivalent to pph in a cesarean section patient. So it is that significant, and you need to know whenever you are not able to find a proper cause of blood loss or of anemia, then always check your stools because they might have an answer to your anemia etiology. Now that we are speaking anyway about all these infestations, is there any other one that leads to defect in iron absorption? Not blood loss, but iron absorption, any infestation?
Sir, malaria, schistosomiasis.
Okay,
Ascaris can also
anything else?
cause
Very common, traveler's diarrhea.
leishmaniasis.
Leishmaniasis, bapre, kala azar. That is that is Kala Azar in pregnancy. I'd be terrified. In fact, I'd be so terrified that I haven't ever seen it. I'd not have any idea. Why and what to do for it? No, something more common, like probably many Indians have it, in fact. GRDSS, very common, malabsorption. So GRDSS is going to cause malabsorption, and that is also going to impair your iron absorption. Anyway, so hematuria, hematemesis, and hemoptysis, basically blood loss from all your orifices. No history of chronic diarrhea. Okay, chronic diarrhea, malabsorption syndrome, fine. No history of worms in stools, rules out infestations, and which is a drug of choice, by the way, for these infestations.
Sir,
So
albendazole
parental
can be
pass.
Correct. So albendazole, what is the dose?
400 mg, sir.
400.
Yes. How many days do you give it for?
Sir, we would give it 14 to 20 weeks of trimester, sir, around for 3 days, sir. If it is mebendazole, 100 mg is given, sir.
No, you just give a single dose, stat dose. You don't give it for 3 days. It has its own limitations. It is a single dose that you give in pregnancy for anemic women. 400 milligrams, single dose, enough. Nothing more required. The dose that you mentioned for 3 days is for significant infestation. Like if you're having a ball of worms, that is a surgical emergency. In fact, all of those causes may require those high doses. We do not require them. Okay. Next is if worm infestation is found, then nothing. You just have to give the same thing. You have to give whenever there is a worm infestation. The first thing you have to know is you have to find the cause of that worm infestation. Often a history of pica is there in these patients, wherein they eat mud or they eat wall, जो भी cement paint जो निकलता है, they eat that. And secondly, you have to give them a single dose of albendazole, which suffices. Now that I've mentioned about pica, could you tell me what is pica? You have not mentioned it in history, I guess. Uh, Pica, what is pica?
Sir, it is a
Urge to eat
urge
unedible
to
Yes, continue. It is the
urge
So
to
urge
the
eat.
to.
eat the unedible substances like mud and also.
Okay, very good. So why? What is the reason for that?
So in case of iron deficiency anemia, there will be she will be having an urge to eat anything
What all are the substances that constitute pica?
like
Chalk,
ashes, like hair glue, sir.
chalk,
What hair glue? Okay. What else?
chalk,
Mud,
sir,
sir.
mud, chalk.
Okay. So there are many reasons why pica develops. One of them is that iron is a crucial cofactor. There are many cofactors, but iron is one of them that is essential in your production of dopamine and serotonin, basically in the metabolism. So whenever there is iron deficiency, it leads to slight decrease in the levels of dopamine and serotonin in your brain, and as neurotransmitters they reduce. That induces an urge to eat these abnormal things. It can also include your ice or your soil, mud or chalk or wall के जो parts बाहर आते हैं. Apart from that, remember that iron deficiency anemia is often concomitant with various types of nutritional deficiencies, which includes vitamin B deficiency. It is basically a complete spectrum of nutritional deficiency. Now, we all know that vitamin B deficiency is going to cause glossitis, angular cheilitis, all these things. So these angular cheilitis and glossitis, it makes it very difficult for people to eat normal food, especially masala and everything, all the or salty food. It causes a burning sensation. So to relieve that, these people start eating those things which will not irritate that inflamed mucosa, which includes things like ice or chalk. And hence, these are the reasons, major reasons. Also, by the way, in zinc metabolism, iron is very important, and a deficiency of zinc can also induce the same changes in your brain in dopamine and serotonin. So, these are three major reasons why pica is going to occur in a patient with iron deficiency. I hope everyone understood these reasons. These reasons are hardly ever mentioned, but if asked in the exam, if you answer this, पक्का guarantee है इधर तक अगर पहुंचे हो then you are going to be getting very good marks in your exam. So I hope everyone understood. Please let me know in the chat. Next, you have mentioned no history of bleeding or leaking PV and no history of fever with chills and rigor. Again, same chronic inflammation. Fine. Next slide. Conceived spontaneously after 2 years. Last booked and immunized. Okay, 9 antenatal visits completed. Okay. Next slide. First trimester, pregnancy confirmed. No history of nausea and vomiting. Nausea and vomiting. Why is it important here?
Sir, hyperemesis gravidarum, dehydration.
Hyperemesis gravidarum. Okay, very good. So nutritional deficiency, correct. What about fever with rashes?
Any
Torch,
congenital torch
torch
infection, sir.
infection.
Okay, correct. Torch infections, fine. Okay, I'll give it to you. No history of radiation exposure. Okay. No history of drug intake. No history of bleeding PV. No history of pica. Folic acid was taken and it was given. Okay. Do you give iron supplementation in the first trimester? Is it good to be
No,
given?
sir.
Is that a
We don't
thing?
give iron supplements. So we can either
Okay.
advise iron-rich diet food. If the patient is very severe, then we can go for blood transfusion in first trimesters.
Okay, very good. Uh, are you sure that we don't give oral iron, or is it like okay if you give it? What if the patient is saying that she absolutely has no nausea and vomiting?
Then we can give, sir. Due to side effects, we are avoiding iron deficiency.
Very good.
Iron,
So it is a side effect that is my concern. But what if your patient has an anemia of, let's say, HB of 7.5, and the patient also has oral intolerance? She's having gastritis. Would you give IV iron in the first trimester?
no,
No,
sir.
sir.
IV iron is completely contraindicated.
Indicated.
Why?
Like, so it is IVIN is phytotoxic, sir.
Fetotoxic. Okay, you are getting very close to it. Why is it fetotoxic or embryotoxic? In the first trimester, it's an embryo. Why is it
Okay.
embryotoxic?
So free radical formation. So
Excellent answer. So the free radical formation that occurs because of iron, a lot like what happens with glucose as well, in diabetes, chronic over diabetes, that can be teratogenic and can lead to spontaneous abortions or malformations. Now, this is a very theoretical risk, but we wouldn't even want to take a theoretical risk. And I'm okay in the first trimester if I'm in the period of organogenesis, if the patient is having moderate anemia. If it is severe enough, I'll give her blood. If it is moderate or mild, I'll just treat it later on. So, yes, correct answer. Now that we have anyway spoken about all these ions, could you tell me what are the forms of iron that we have available?
sir, oral iron forms and parental iron forms, sir.
Oral iron forms and parental iron forms. Okay. By the way, before we proceed, we have posted the feedback form link in the comments. Kindly fill them for the attendance and certificates. We would love to know your responses. It is there in the chat section. Yeah. So iron formulations, oral and IV. Could you tell me what are the oral formulations that you know?
Sir, ferrous sulfate, ferrous fumarate, ferrous gluconate, and ferrous ascorbate, sir.
Very good. Which is the best one?
Ferrous sulfate, sir.
Are you sure about ferrous sulfate, or is it the one that is widely available?
It's widely available, and for lower socioeconomic status, it is easily affordable, sir. So we can.
Okay, but it causes a lot of gastritis. Patients are very uncomfortable, so they prefer some other salt. So, which is the other salt that you can get?
Ferrous ascorbate is preferred, sir, because it has
Yeah,
higher
ferrous ascorbate.
bioavailability.
Very good. So, the advantage with ferrous ascorbate is the presence of ascorbic acid in it, or ascorbate compound in it, which increases
And
the iron absorption. So, what are the reasons in which, or what are the ways in which you can increase iron absorption?
sir, we can give along with calcium supplements, sir.
What?
Sir,
Along with
sir, we
calcium
should not.
supplements, that is
No, sir.
absolutely
Sorry, sir.
wrong.
Vitamin C, sir. Sorry.
Okay, yeah, vitamin C. What else?
Sir, and we should take an empty stomach, sir, so that the HCl secretion will increase the iron absorption, sir. And phytates and tannins should be avoided up to 1 hour after we take iron, sir,
Okay, but
supplements.
what are phytates and tannates? How do you explain it to the patient?
Like
Tea,
tea, coffee should be avoided, sir.
Okay, very good. Tea, coffee, and leafy vegetables. Very important. Green leafy vegetables. Okay. Your patient tells you that I do not believe in all your allopathic form of medicine. I find it nonsensical. I will only believe in eating fruits and vegetables. You tell them that fruits and vegetables are not adequate enough. They are not agreeing with you. They tell you, please explain me logically. I'm an educated patient. So can you explain why diet is insufficient and why are supplements required?
Sir, only 10% of absorption will happen, sir, if she
Yes.
takes in dietary. So when we give like oral supplements or parental supplements, like we'll give around 200 mg, sir. So in the 10% is around 20 milligrams, sir, which satisfies our RDS, which satisfy requirements.
Do you
And
think
there is
200
an
milligram elemental iron in first place? 200. That's a lot. You're overloading her with iron. What is the recommended Anemia Mukta Bharat latest guideline? What is the latest guideline on how
TMG of
much of
elemental ions.
how many? How much?
60, sir. 60, 60.
Yeah, very good. 60 because 10% of 60 because anyway the absorption is only 10%. So 10% of 60 is 6 milligrams and 6 milligram is the requirement RD that is recommended daily allowance for iron during pregnancy. Whereas if you do not take those supplements, if you only rely on your diet, you are only going to get 1 to 2 mg, which is very less. But still, they say that I don't believe this. So now you are forced to tell them what are the good sources and bad sources of iron. Could you tell me what are those sources and how do you recognize them?
Sir, if she is a non-vegetarian, I would advise her to take organ meats such as liver, sir, and
Yes,
kidneys
very
of
good.
goat and fish, egg yolk. And she's a vegetarian, then green leafy vegetables, cereals, pulses, jaggery, ragi, and dates, sir.
Excellent answer. And which is one of the worst forms of iron?
Milk,
One worst form
milk,
of
sir.
milk. Very good. There is a very classical way in which people fortified their food with iron. How was it?
Sir, in India, we have fortified iron with rice, sir.
Okay, very good answer. That's a good answer. What else? How can you do it on a daily basis? A lot of people do that.
We can, without,
Fortified salt, sir. Fortified salt, sir.
Okay,
sir, we
fortified
should
salt, that
add
is
the
good.
starchy water of the rice and we should not discard it, which will
Okay,
improve.
what else? A
Like
lot of people are
cooking,
mentioning
cooking within
jaggery.
cooking with
Is
iron
it
utensils, sir.
iron utensils? That is what I was waiting for. So cooking in iron utensils, but there is one problem to the implementation of this. What is that problem?
She might overcook it, sir.
She might overcook it, and if you're cooking it for long hours, for a longer duration, it can release oxide, ferrous oxide, or
Okay.
basically oxidized form of iron, which is toxic, in fact. So, which is why they wouldn't know at what temperature for how long all these things, and hence you would end up, in fact, giving them iron toxicity and toxic compounds in their body, which is why that cooking in iron utensils is kind of something you shouldn't really recommend. If there is no option, then it's okay. But if there is an option, then don't. And you do have an option because Anemia Mukta Bharat does provide for it. Anyway, before going there, people are mentioning jaggery. Would you like to use jaggery as a source of iron supplementation? Is it a good source?
Yes, sir, it is a good source of iron.
Hmm. Uh, who is the one who answered this? Arjun or Ranjit?
Uh, Arjun, sir.
Okay. Ranjit, do you have any other perspective towards this?
No, sir.
A lot of our seniors, a lot of our faculties give this answer as yes, we should be giving jaggery. I completely disagree with that. The reason is jaggery contains truckloads of sugar in it. If you have to supplement a person or a female with 6 milligram of or 60 milligram basically जिसका 6% absorb होगा 60 milligram of elemental iron through jaggery, you would have to give her in several kilos, and that is eventually going to lead her into having diabetes mellitus. I do not want to treat anemia and give her diabetes mellitus. So you are loading her with sugar merely to get some grams of iron, which is why it is not an acceptable method. It does contain iron, but it cannot be your sole form of iron corrective measure. So the answer is no. Jaggery is not a good source of iron. What is the meaning of a good source of iron? The concentration of iron per gram of that food material like organ meat is very high. In this, that concentration is very low, and instead the glucose, the glycemic index is quite high. Hence, jaggery cannot be recommended. Then Anemia Mukta Bharat came in and they have made a provision for this. What is the provision that they have made for correcting anemia?
To
Sir,
supplement essential,
Yes, continue.
sir, iron and folic acid tablets can be given, sir, and
Yes.
deworming,
Which are the color of
deworming.
tablets that are available?
red color, sir.
Okay. And is there any other tablet that is also available? There are two colors of capsules or tablets that are made available by Anemia Mukta Bharat. What are those?
Red and blue, sir.
Yes, red and blue. Okay. But what is the difference between them?
Like one contains only folic acid and another contains both iron and folic acid. So,
Oh, are you sure about this?
no, one should be taken till pregnancy and red should be taken during pregnancy, sir.
Okay. So the thing is, both contain the same thing. Both contain 500 milligrams, sorry, microgram of folic acid and 60 milligram of elemental iron. But the reason the color is different is that blue tablets are more so meant for non-reproductive and adolescent females, whereas red, or rather only for adolescent females, whereas for reproductive age women and pregnant women, you give the red tablet. Why? Or red capsule. The reason is the society is going to say that if I'm going to be giving the same red tablet to a 30-year-old pregnant female, and if I'm going to give the same tablet to a 15-year-old unmarried female, they will say that you are loading my kid with plenty of iron. You are giving her the same iron as the other pregnant female is receiving, and there is something wrong with it. So for this social taboo, they have ensured that they give a blue color tablet for all these younger females or younger people. Whereas the red tablet, because red is synonymous with blood and pregnancy, you keep it for those reproductive age females who menstruate and are also going to get pregnant or are already pregnant. What is the dose, or what is how many times do you have to take it in a single day?
Sir,
Once a day.
60 mg.
60 mg once a day. This is the prophylactic dose to prevent anemia. What is the corrective dose of anemia?
2 doses should be taken, sir.
Yes, two
Twice.
capsules have to be taken. What is there any formula for me to calculate how much of dose do I have to give?
Yes, sir.
Yes, sir.
Galaxy's formula, sir. 2 point
Which formula?
Galaxy's
Galaxy. Ganzoni's formula. What is the Ganzoni's formula?
2.2 into pre-pregnancy birth body weight into the hemoglobin deficit plus 1000 mg iron. Sir.
Okay, very good. So a few centers use it as 500. A few centers use the value as 1000. What is this 500 or 1000 value?
it is iron required for replenishment of the stores, sir.
Very good. So iron store replenishment, it is very important. Now that we have anyway spoken about iron stores and iron deficiency, could you tell me what are the stages of iron deficiency anemia?
Like first there is negative iron stores, sir, and second one is iron deficiency erythropoiesis, and third one is iron deficiency anemia, sir.
Okay, very good. So in the first stage where you mentioned about iron, negative iron balance, which are the parameters in the blood that are affected?
Sir,
How would you
bone
tell
First,
me?
marrow iron and serum ferritin will be low, sir.
levels will be first
Serum
drops.
ferritin. Is the serum, since you have mentioned that negative iron balance is going to be there in first stage, is it going to reflect as low serum iron?
No, sir.
Very good. So when is it going to be diagnosed?
In stage 2, sir.
In stage 2. Okay, so iron deficient erythropoiesis. So in iron the deficient erythropoiesis, the existing parameters, that is serum ferritin and TRBC increasing, will stay. But along with that, your transferrin saturation is going to fall and your serum iron is also going to go down. And what is the diagnostic finding in the third stage, that is iron deficiency anemia?
So there will be increased TIBC, sir, total iron binding
No,
capacity.
that is there since your first stage itself. What is a very classical specific finding for third stage?
Bone, the serum ferritin will be dropping, sir. Transferrin
That is
saturation level
right from your
will be
first level, first stage. What is the most specific factor? for
Currently,
iron deficiency anemia? Third stage.
it will be a normocytic and microcytic with hypochromic anemia.
Exactly. So your peripheral smear is going to show changes finally in your third stage, that is frank iron deficiency anemia. So your third stage, very specific finding is the peripheral smear finding that you're going to see, that is hypochromic microcytic anemia. Okay, so these are the three stages of iron deficiency anemia. And we were talking about all those formulations, oral formulations. If your patient is getting GID on one formulation, what do you do?
Sir, if she's,
What?
we can, if the oral compliance is not good, we can go for parenteral iron therapy, sir.
Is that what you do? Your patient has come to you, she's consuming ferrous fumarate and she says that she's getting gastritis. What do you do next?
Sir, I cannot
Recommended
give
to take along with the this one, sir.
No, she's done
Along with the
everything,
milk,
but it is just, she's just not tolerating it. What is the next step? Definitive step.
like we can advise her to take during her sleep, sir. Like before sleep.
What? During sleep? You would
Sir,
have to
sorry,
insert an RT tube, RT डाल के उसको नींद में डालना पड़ेगा. That is literally like forcing iron into her body. How can you take
before
anything during
sleep.
sleep?
Sir, sorry, sir. Before sleep, sir.
Or before sleep. So when she lies down, her GRD is going to be maximum. The solution to GRD is to stay awake or to have a head high position. You cannot be asking her to sleep after taking iron. You will change her salt. You will ask her to substitute the salt. Fumarate ka make it ascorbate. If it is ascorbate, make it gluconate. Basically, you will first try changing the salt. If that doesn't work, then you go ahead and you give them intravenous or parenteral formulation. What are the parenteral formulations that are available with you?
sir, iron dextrose.
Iron dextrose. ये
Sorry,
नया है
sir.
क्या कुछ?
Sorry, sir. Iron dextrin and iron sucrose and ferric carboxymaltose, sir.
Okay. Do you think you would want to just classify it into intramuscular and intravenous preparations?
Yes, sir.
Intramuscular is iron dextrin, iron sorbitol citrate complex, sir. In intravenous,
Yes, very good. And intravenous is?
iron dextrin, iron sucrose, and ferric carboxymaltose.
Yes, very good. Which is the best currently available?
Sir, ferric carboxymaltose.
Very good. Ferric carboxymaltose, or what we call as FCM, is a very good one. Why is it better than ferrous sucrose that we were giving until now?
Sir, in
Large
ferrous
dose
sucrose,
can
there is a
be
limitation of
administered at
about 200 mg per day, sir. But
Yes,
in whereas if we compare with ferric carboxymaltose, we can give up to 1000 mg in a single dose, sir.
yes, correct. So basically, you don't have to keep the patient admitted for 5 days to administer her this. But then, if it is so good, if you can cover up 1000 milligram in a single day, your elemental iron is only going inside at 60 milligrams per day. उसमें से भी 10% ही absorb हो रहा है, so it is 6 milligram that is getting absorbed. 6 milligram एक जगह पे 1000 in the other. Why not just give one single dose of IV FCM for everyone? Assume you're getting
Sir,
it for free. Why not?
There are like side effects like pain, skin discoloration, sir.
Yes, very good. What else? What is the most
Throm
important dangerous complication?
abscess formation and thrombophlebitis, sir. And anaphylaxis can also occur, sir.
Anaphylaxis, very good. Death can occur. Patients, I have seen a patient who has died because of iron sucrose administration because of anaphylaxis. I've seen two IUFDs because of anaphylactic shock leading to loss of fetal uterine perfusion. For all those people who are seeing expensive, now in Mumbai we get FCM for just 800 rupees. 6, 700, 800 rupees, which has become very affordable. During my residency 3 years ago, it was around 2500 to 2000. Now it has come down to 800. So it is not that expensive now. But the point that um, Arjun and Ranjith have mentioned is correct, that they have a lot of side effects. You mentioned about skin discoloration. What is the name of that disorder? So the answer is iatrogenic cutaneous siderosis. Iatrogenic is basically something that has happened by something that the
Medical
doctor has
procedure.
done. Yeah, medical procedure. Cutaneous is skin. Siderosis is iron deposition. So basically, literally like tattoo, how your tattooing is going to occur. The same way, these iron molecules get deposited under your skin and they stay there for several years until the lymphatics absorb them, which takes several years and it leaves a permanent patch which is very ghastly. It is just very bad to see. And this happens mostly in ferrous sucrose because the IV line that you have inserted is often the blue IV line, and that blue IV line is going to stay in situ for several days because only 200 milligram can be given in one day. And hence, the IV line, it extravasates or there is superficial thrombophlebitis, the vessel gets blocked. And if you do not check the patency and you directly attach the dose of iron sucrose, it goes out, it extravasates. And that leads to deposition of iron underneath the skin. So cutaneous, iatrogenic cutaneous siderosis, very important skin complication or skin discoloration because of iron. Next slide. Yeah. Anyway, parental iron. Okay, so you can give FCM. Very good. So tell me, there is a patient whose HB is 8 and she is tolerating oral iron. I give her oral iron. And there is another patient who is not tolerating oral iron, so I'm giving her FCM. In whom is the HB going to increase faster?
In both
Sir,
the
in both.
patients, the same, sir.
Yes, very good. So the rate is going to be the same irrespective of your mode of administration. So what are the changes that start occurring in a patient after you administer iron?
So first the patient will be like she should have general
Sir,
General,
first there will be a sense of well-being will be improved in the
well-being,
patient.
sir.
Sir. Then
very good. So
increase in
sense
the
of
uptake.
well-being.
Yes, sir.
And there will be increased appetite, sir.
Yes, very good. Increased appetite and well-being. Very good. So how long does it take for this to start occurring?
Sir, it will occur within 24 hours of administration of.
24, I would say 5 to 7 days. 24 hours
Okay.
is a little too fast. 5 to 7 days. Within a week, she will have those signs. What are the these are the symptoms that improve. When do the signs start improving? What is the first sign of improvement?
Increase in the reticulocyte count, sir. Around
Very
five to
good. How
seven
long does it
days.
take?
5 to
Five to
7
seven
days.
days.
Yeah, very good. 5 to 7 days, you would start seeing increase in the reticulocytes. Reticulocytosis is going to be seen. And how long before the HB starts increasing gradually?
Around 2 to 3 weeks, sir.
Correct. Perfect answer. 2 to 3 weeks. And depending on how severe an anemia is, it will take utana period of time for it to improve, which is approximately to become normal. It takes 1 to 2 months, 1.5 months. But yes, within 2 to 3 weeks, it will start increasing gradually. Correct. So that is it. This is it about your iron preparations, your intramuscular, intravenous, and your oral iron formulation. Okay. What is your indication for giving blood transfusion?
Like
Sir,
if there is any severe anemia in any gestational age, sir,
Yes, severe anemia at any gestation, first, second, or third trimester, doesn't matter. What
and if there
else?
is no response to iron therapy, sir, parental iron therapy, sir, and IRIDA, sir.
Okay, very good. So no response to iron therapy, fine.
If there
Um,
is
Now
any
that you have mentioned about no response to iron therapy, what can be the cause of that?
like if it is IRIDA, sir, iron refractory iron deficiency anemia, sir. It
Okay,
could be a cause.
and what are the other more commoner causes of of anemia that are not responding to iron?
sir,
Malabsorption syndrome, sir. If we give oral and if she doesn't respond,
But that is going to be a form of iron deficiency anemia. What I'm saying is, what are the other parallel forms of anemia wherein iron
vitamin B12
deficiency is not the
deficiency and
cause?
folic acid deficiency, sir.
Very
uh,
good. So nutritional
thalassemia,
deficiency,
right,
B12
sir?
and folic. Yes, thalassemia. That is the answer I was looking for. Which is the test, or which is that simple test that you see on a CBC report and you know whether it is thalassemia or iron deficiency?
High performance liquid chromatography, sir.
No, no, no. That is the one of the best tests. But just on a CBC report, how do you get to know
Iron
whether it is
studies, sir.
thalassemia?
Iron indices.
CBC
Total
report,
iron.
a complete blood count.
Okay. The total iron binding capacity.
How do you
Normocytic,
see total
normochromic,
ending?
sir.
How do you see this on a CBC report? One very simple formula. What is that formula? Everyone has answered it in the chat.
Genster index.
Yeah, Menzer index. What is Menzer index? What is the
So
formula?
if it is less than 13, it will be mostly thalassemic traits, sir. And the Menster
Okay.
index, MCV divided by MCH, sir.
Okay, fine. Correct. So what is the formula?
MCV divided by MCH, sir.
MC.
MC
What?
divided by RBC count, sir.
Okay, yeah, correct. Yeah, correct answer. Fine. Okay, yeah. Now you were mentioning about high performance liquid chromatography.
Yes, sir.
Which is the test of choice? Which is the test? Listen to my question properly. Which is the gold standard test to diagnose thalassemia?
Hemoglobin electrophoresis, sir.
Which is also why I said listen to my question very properly. Which is the gold standard test?
Gene testing, sir.
Excellent answer. It is genetic testing, genetic locus. So you get various genetic foci. You get various genetic foci which you have for all the thalassemias and sickle cell anemias. Remember that whenever you do HPLC or electrophoresis, it only shows a band of which type of hemoglobin is increasing. I think my voice is echoing in one of the way. Nalam Nirosha, kindly mute yourself. Okay. So the point is, in that you only see a band at which form of hemoglobin is increasing. Is it HbA1, is it HbA2, or is it HbF? But whenever you do a genetic testing, it is a little more expensive, of course, but it gives you a definitive diagnostic test. It is your definitive way of knowing whether that female has thalassemia or not. Why is it important? Remember, it has autosomal recessive pattern. So if a female is going to have thalassemia in her, if the husband also has a form of thalassemia, I will do dono ka genetic testing. I would know which exact gene is affected, and that gene is going to be what I'm testing in the fetus by doing the amniocentesis so that I know whether that fetus also suffers from thalassemia and is it thalassemia major. So that is how I do not do, whenever I do amniocentesis, I do not do HB electrophoresis. What I do is genetic testing because that is the only definitive way of knowing which form of thalassemia or sickle cell anemia or which hemoglobinopathy basically is present. So you are correct. The answer is genetic testing. Okay. Um, yeah. Okay. So we were talking about all the parallel forms of anemia. So could you tell me how is classification of anemia done? One was your on the basis of etiology. What is the other classification?
Acquired or inherited, sir.
What?
Acquired or inherited forms of anemia, sir. And in that
Okay.
hemolytic, non-hemolytic.
Yes, very good. So acquired or not, correct. Etiology, yes.
Based upon
So
reti count also, we can classify as hypoproliferative or hyperproliferative.
okay, fine. That is one of the ways. It can be on the basis of severity, it can be on the basis of etiology, or it can be on the basis of production or destruction excess. So basically, places wherever there is a reduced production, that is aplastic anemia, or where there is more destruction, that is hemolytic anemia, that is another cause. So what are the various types of anemia? Just quickly enlist. You have already mentioned about nutritional anemia, you have mentioned hemoglobinopathies. What else?
Enzyme defects, sir.
Enzyme
Maybe
defects
like G6PD deficiency and
okay, G6PD, one more.
this
One more test.
pyruvate
One
kinase
more.
deficiency.
Pyruvate kinase.
Yes, or 5-nucleotidase deficiency.
Yes, correct. Very good. Uh, okay, fine. Uh, that is it. Fine. These are the classic types of anemia. Fine. Go to the next slide. Okay, so all these anomalies scan normal. Weight gain is fine. And folic acid was given. No history of headache. Okay, blood pressure normal. Next slide. By the way, if your patient has sickle cell anemia, which are the drugs? Which are those specific drugs that you give to that patient? Arjun, Ranjit?
Uh, we can manage with good hydration, effective analgesia, prophylactic antibiotics.
Okay, but which specific drugs? Someone has mentioned hydroxyurea. Hydroxyurea is teratogenic. It has to be stopped 3 months prior to conception. Shweta, we cannot give hydroxyurea. There are three very specific drugs that we give to these patients. Which are they? So one of them is what you have mentioned, that is analgesics that you give for all those pain crises. Secondly, you give aspirin. Aspirin is so that there are no platelet plugs that are forming. Endothelial dysfunction is going to occur in these patients because of chronic inflammatory state. So to ensure that fetal perfusion is normal, you give ecosprin, that is aspirin. And the third drug is what you give on admission. Every time you admit the patient for whatever cause, it can be hyperemesis gravidarum, it can be a severe IUGR, which will eventually show up. In that scenario, you also give to these patients LMWH or unfractionated heparin because these patients are at a high risk of developing DVT. So, in a patient with sickle cell anemia, every time you admit them, you give them lots of fluids, you give them analgesia and also LMWH. So, these are the few important things that you have to be checking for. Okay, next slide. Okay, next slide. Fine. Next. Okay, next. You have mentioned about no history of contraception usage. Could you tell me what is the significance of that in this case?
Sir,
So whenever you're giving any contraceptive agents, it very often corrects your abnormal uterine bleeding or heavy menstrual bleeding that corrects your anemia prior to pregnancy. So that is the reason why history of contraceptive consumption, especially OC pills or POPs, before has to be ensured. Now that I've mentioned this, could you tell me the dynamics of iron during pregnancy? How much of iron is saved because of amenorrhea and how much of iron is used up for the placenta and the fetus?
Like
yes,
300 milligrams is saved, sir. And for placenta and blood transfusion, it requires 500 milligrams. And for
sir,
this,
maternal increase
and
in RBC around 500 mg is required, sir. And there is a basal loss through urine and sweat of about 200 mg and blood loss at delivery of around 300 mg, sir. So totally, from the iron saved, it will be minus 300 and we'll get 1000 mg, sir.
Okay, correct. Fine. Next slide. Okay, next go to the examination part. Okay, so HB of 7.3. How do you manage your patient at this point?
we'll
She's
go
in
with
36.
since she is beyond 36 weeks.
Okay, so what will you do?
Sir, we can go with parental iron therapy, sir.
Okay, 36 weeks. So basically, she is nearing delivery and she has moderate anemia, 7.3. Would you want to wait upon for parental iron to act upon?
No, sir. Like blood transfusion followed by parental iron therapy, sir.
Okay, fine. That is something you can definitely do so that even postpartum period mein the HB can keep on increasing by the iron supplementation. Okay, fine. So blood transfusion is going to be a mainstay of management in this case. Could you tell me what are the maternal complications that you expect in anemia apart from the ones that you have already spoken? Intrapartum complications?
Sir, uterine inertia and
Yes.
congestive cardiac failure and shock, sir.
Okay. Shock. Okay, very good. Anything else? Uterine atony.
Antenatally,
Inertia is a better word is atony because the uterine muscles are not getting enough oxygen
yes,
for for oxygen for them to contract and involute. So that is one of them. What else? Increased risk of infections, do you think? Because patient is
yes, sir.
nutritionally deprived anyway.
Antenatally, there will be an increased risk of infections, increased risk of preeclampsia, preterm labor, and congestive cardiac
Yes, very
failure.
good. Why preeclampsia? You have mentioned very correctly. Why preeclampsia?
Due to
Sir,
stress, hypoxia.
A better answer.
there will be more protein loss, sir. So the all the
No.
iron resource.
So Steve, to compensate for that anemia, there is going to be placentalomegaly. And that placentomegaly, bigger the placenta, more
There
the
is reaction.
possibility of, yeah, more the possibility of, just like in multiple gestation or in gestational trophoblastic disease. The same reason is going to apply here, that placentomegaly because of anemia is going to lead to that. Okay. Um, why infections? Increased risk of infections.
Sir,
Reduce oxygen delivery to immune cells, sir, which impairs the function of immune cells, and iron is required for enzymatic actions involved in the immune reactions. Sir.
Yes, very good. So the second reason is correct. And also because of lower immune status, you will easily contract all of them. So lower immune status because of lower nutritional status, because these patients are probably going to be poorly built. So all these conditions are going to predispose to infections, and hence preterm labor as well, because infections are going to increase your prostaglandins because of all the cytokines that increase in your body, and prostaglandins are going to initiate preterm labor. Fine. So intrapartum, if your patient has severe anemia, is there any more precaution that you will take?
sir, can you repeat it, sir?
If your patient has severe anemia in labor, how do you manage it? Or is there anything specifically that you would want to do?
Will reduce the
Sir,
exhaustion caused during labor, sir, by administrating
second,
oxygen, and we can transfuse during labor, sir.
Yes, definitely I'm transfusing. First thing is transfusion. Secondly, I would also want to measure a CVP or at least see a JVP so that I don't over transfuse it because our heart is already over functioning. So I would want to check for signs of heart failure, first thing. And in second stage, something that I'd want to do.
Cut
sir,
short the second stage of the labor using outlet forceps, sir.
Very good. So I would want to prevent tachycardia because of bearing down, because that tachycardia is going to worsen the cardiac overload that will push her into cardiac failure, anemic heart failure. And hence, I would want to use forceps for severe or very severe, more so extremely severe or very severe anemia agar hai less than 4 HB, then I would preferably want to use I would want to use forceps. But you have to remember that forceps will also increase the risk of you giving a genital tract trauma, which is going to bleed further. So you have to balance both these factors, that you shouldn't even give that female genital trauma, and also you have to prevent her from bearing down. Okay. Apart from that, IV antibiotics intrapartum you will give to prevent infections. Okay. One point that I missed about intramuscular iron, which we don't usually give. What is the technique to give intramuscular iron?
Z
that
technique, sir.
track techniques, sir.
Why Z-tag technique is used?
It reduces the staining of the skin, sir.
It reduces the staining of skin. Yes, correct. And how is it done?
So the
Sir,
patient is in the lateral position and inject. We should inject at the uppermost part, sir. And the we have to slide the skin over, and it should be given perpendicularly to the skin, sir.
Yes, correct. So basically, you have to pull the skin to one end and then you have to inject it. And then once you're done with the injection, you just leave the skin so that the point at which you have inserted or injected it inside the muscle is not the same point at which you have entered into the skin as well. So those two are different points, and hence they are not forming a single straight tract. And if the tract is not formed, all that iron is not going to track out and is not going to lead to skin discoloration. So that is called as a Z track technique, because your skin goes in a Z direction. The skin and the muscles go in a Z direction. So that is the way of giving it, but we do not practice it anymore. We do not give intramuscular iron because it is very painful and leads to a significant lot of abscess as well as anaphylactic reactions. Okay. Uh, now that you have delivered your patient, what is post-delivery advice that you will give?
So we have to advise her to take the iron supplements for another 3 months, sir.
Okay, another three
And
months, not 3 months. In fact, more than that, until she's lactating, I would want her to take those iron
3 to 6
supplements.
months.
Yeah, and apart from that, I would also want to advise her on contraception so that
usage.
she doesn't conceive anytime soon. I would want to give her something like Mirena or even copper tea so that she doesn't conceive in future. Correct? And Mirena is also going to reduce her blood loss eventually
Bleeding.
whenever she starts menstruation. Okay. Last question for the day. Anemia Mukta Bharat. Just quickly tell me something about it apart from the tablets.
So it was
Sir,
launched in 2018, sir, by
Okay.
Ministry of Health and Family Welfare. It consists of 6x6x6 strategies, sir.
it had 6
There are six.
beneficiaries, sir, where children of 6 to 60 months were, and adolescent girls from age 15 to 19 years, and adolescent boys were also included. Women of reproductive age group and pregnant women and lactating women were included in this program. And iron and folic acid supplementation of about 60 milligram of elemental iron with 500 microgram of folic acid was given in this program for a minimum of 180 days, sir.
And
From
the
starting from
six interventions are prophylactic iron and folic acid supplementation and deworming with albendazole 400 milligrams and intensified year-round behavior change, sir. And we have to encourage the people to take iron-rich foods through diet, sir. And testing and treatment of anemia with special focus given for pregnant women and provision of iron and folic acid fortified foods and intensifying awareness and screening and treatment of non-nutritional causes of anemia, sir.
Very good. एक number answer दिया है, and I'll be very honest, even I didn't know all this because I've forgotten it when I gave my exams. But yeah, correct answer. Very nice. And with that, we would want to end today's Viva. So let us just answer a few questions that were asked. Is it recommended to take one IFA pill per week for women of reproductive age? So what is your opinion on this, as most of us don't take it? Should we be more serious? Hafsa, that's a good question. That's a very good question. It is a lot like females in my own family not taking calcium supplements in their perimenopausal group. So it is basically a lot of females or a lot of reproductive age females get uncomfortable over the fact that it is causing gastritis to them or it is causing black stools, which is why a lot of females abandon taking it. So what is the right practice? I would say that every female of reproductive age should at least do one CBC annually or every 6 months. If her HB is below her normal range of 12 to 13, if it is anything below 12, I would then recommend them to take it. Ideal hai, it should be taken, but you would not find people do it, especially once a week. They would not believe. So it is a thing of it's a cultural thing. I don't think females will agree to that gastritis wala aspect. So at least do a CBC and keep a track of how your HB is. If it is low, then take that therapy. Is what is a practical solution to it. I mean, obviously, if you are going to tell someone to take one tablet every week for the rest of her life, she's not going to do that. Instead, if there is some problem, then you treat it for 1 month and then be assured कि अगले 6 महीने में तो patient को कोई होगा नहीं कुछ. Apart from that, there were a few questions that were asked earlier in the session. So those questions, okay, I cannot find those questions now. I think those questions may have been deleted, but okay. So that is it from today's session. If anyone has any doubts, kindly ask them in the chat. It is said to stop oral and before parental and how it causes toxicity. No. Shweta, that's a very good question. Should we stop oral iron before parental iron? Arjun, Ranjit, do you want to answer this?
Yes, sir. We should stop before 24 hours since it causes
Why?
toxicity, sir. Iron
Is it
toxicity.
because of toxicity or is it because of some other reason? See, your
Toxicity.
toxicity is not going to really make a difference because 60 milligram per day de rahe ho oral iron. Whereas you are going to give 200 if you're giving iron sucrose or even directly 1000 if you're giving FCM. So it doesn't have much of a bearing. The answer to this lies in the fact that your iron receptors on hemoglobin are going to be saturated partially because of that oral iron. I do not want that. I would want them to be desensitized. I would want to be them to be sensitized and not be desensitized, which is why I would want to stop her oral iron a bit of time before I'm giving her parental iron so that my parental iron therapy acts optimally in her body. So rather than toxicity, it has more to do with the receptors and the transference saturation levels that should make sure that the parental iron therapy works better. So that is the reason we prefer to stop it a few days before your therapy and we do not give it concomitantly. Toxicity doesn't really occur with those levels because 200 दे रहे हो 1000 दे रहे हो 60 milligram से क्या ही होगा. Okay. So that's it for today's session. I have already posted the feedback link. Kindly fill everyone. Ranjit, Arjun, you were pretty good. There were a few aspects which could be improved. I think Arjun was answering it really well. And those minor aspects, not much. You have read most of it. Otherwise, I don't think there is much scope for improvement. Just the finer aspects. Otherwise, it was a good one. So thank you for this presentation. That was a great effort. And thank you for this short notice and agreeing to do it today. You both were pretty good. And thank you so
thank
much, everyone, for this session. Yeah. And I hope we'll see each other again on Monday night at 10 p.m. And thank you, Arjun. Thank you, Ranjit. Thank you, Simsog. and I'll log out. Please fill the feedback form. I've posted the link in the comments. I've already pinned it. So thank you so much, everyone.
Okay.
Good night.
Thank